Oh my God, too many buttons to press. Good evening.
Evening. Hi, Joachim. How come? I think I didn't set something, but it's fine. We'll proceed.
Where's Karma?
Hello, everyone. I'm glad to be on call today.
Great to see you. We'll be starting shortly. Thanks, Lubecha. Jason, is it?
Yes, it's Jason.
You know, we'll chat just now.
I just reached Carmen. She will connect any moment.
Thanks. Okay, hi everyone, welcome. My name is Shabir Musa. I'm going to just quickly lead you through very briefly some of the technical stuff. We're just waiting for all our presenters to be on board. So we are very fortunate to have a host of visitors, of speakers that I think will be really adding some great value to this discussion in AfroPHC. Let me start by just getting you familiar with the platform. It seems like the numbers are a little lower. So perhaps we can just show this video while we're waiting for some of the people to join us. And I will just also send off some emails just to make sure that people are aware. So give me a second.
The world in which we live and work is complex and rapidly changing, and so are the factors that determine our health. Consider obesity, for example. There are many contributing factors, including heredity, individual food consumption, personal activity levels, social influence, food production, etc. These factors are diverse, myriad, context-dependent, and constantly changing. However, when we fail to consider that complexity in health, we generally address one patient, program, disease, or policy at a time without adequate consideration of the dynamic relationships, diverse perspectives, and invisible boundaries which influence health. Such an approach often leads to unintended consequences. Fortunately, complex problems don't always require complex solutions, but we do need to shift the way we think about health and health improvement. We need to adopt a systems perspective to find solutions to these important, challenging problems. Systems approaches to change have emerged from a wide range of disciplines, including systems thinking, complexity science, system dynamics, and complex adaptive systems. Such terms can be daunting to health professionals who are new to these ideas. However, we've found that starting with three fundamental concepts, as suggested by Bob Williams, can be helpful: interrelationships, perspectives, and boundaries. We will define these three concepts and then show you examples of how relationships and the patterns of between individuals and program activities of other organizations working in the same area. And this can lead to duplication of services in some areas and lack of services in others. It's also important to consider the perspectives. For example, in Mozambique, mosquito nets intended for malaria prevention were delivered through a health organization. However, the nets were instead catching fish. Use was misunderstood, and there was a local need for food. In this example, the local perspective not to be considered. Without realizing it, we form boundaries in our planning and activities that determine what perspectives we incorporate and value. For example, a university public department that individual clinics, organizations, and community relationships, perspectives, and boundaries more earnestly, we will become aware of opportunities for improvement that we may not have previously considered. Here are a few examples of situations in our health work where applying a systems perspective might be beneficial. A physician who receives very little feedback on her work over the course of years may be unaware of the perspectives of her patients. The lack of coordination between various global health initiatives can lead to unnecessary redundancies and inefficiencies created by boundaries between the organizations. Healthcare providers are often paid according to the number of patients that they care for, instead of the quality of care that they provide. Financial reimbursement reform could be a significant leverage point in healthcare reform. Complex systems can be applied to a wide range of health activities. Your experience and context is likely very different from ours. What surprising patterns of interaction might you notice by applying a systems perspective in your sphere of influence? Can you identify boundaries that limit productive collaboration, such as social norms, that limit communication between organizations or cultures? What additional perspectives need to be considered to reach your community's health vision? What new questions are you asking by taking a systems perspective? We, as a global society, need to change the way we approach every aspect of healthcare to incorporate more systems thinking. We need a systems thinking revolution in health practice, policy, research, and education. Thanks to support from the Doris Duke Charitable Foundation's African Health Initiative and the Norwegian Agency for Development Cooperation, we have formed an organization called Systems Thinking for Capacity in Health to advocate for these changes, and we hope you'll join us. Thank you.
Welcome. We're going to go through some brief requirements for us to show you through how to use Zoom as well as Menti. We'd like to get a lot more interaction than we've had previously, so let me just go through some brief guidance. We do have an interpreter, so if you are able to, please go and choose English. If you are, sorry, let me just make sure that's working. So you should be able to now choose an interpreter. If you have any French-speaking people that you can't understand, please choose the English. And if you're French, feel free to use the French translation for you. That's just the translation. Please use the reactions. I think it just gives some feedback to the people that are, providing you the talk. Chat is there. Please use that opportunity to sort of make any comments. Please don't put questions in them. If you look at the bottom right-hand corner, you'll see sort of an icon, hearts, which if you like as well, you can sort of provide reactions there. And then also on the little sort of square is for questions. So please feel free to put those questions. We'll try and do them at the end of all sessions, all the presentations. Participant list, mute and unmute video, you can look at that to see who else is in the conversation. We're going to have to try and manage the conversation, so we'll go through the agenda shortly when our chair joins us, Prof. Joseph Anna, but if he's not, I will proceed to provide some guidance. So let me just go to the next few slides. We'd encouraged you all to join Menti. You can still go through your app store, either on Google Apps or Apple Store, and download that. Just look for Menti, menti.com, and just download it. If you click it open, it will sort of show the screen. I will show one just now that looks like it. All you require, it'll ask for a code. Put in the code at the top, from the top of the presentation. I'll show you that right now. Or you can also do it on a browser where you just have to go to menti.com on your browser and you should see that. So the code is basically what we have today, 61460771. And if you look at the top, this statement, go to menti.com and use the code 61460771. That will be on all your slides. So you can remember that. You just look up at the top and use that code. Once you download Menti, hopefully you've done that already. Again, as I say, you can use the sort of hearts and the question and answer at the bottom. So let's start. If you can all add in, welcome. And Alex, sorry, I'll just unmute you. Sorry. Okay. Okay, so those of you who are speaking French, you should be able to now get some French. I hope Alex will just give you quickly what we'd just talked about. So if you are on menti.com, you can begin, and we'll just give you a few seconds to try and put in what country you're from, and you could begin to give us some feedback. And I think that'll be strongly appreciated by the speakers. Hopefully you've got Menti and getting it going, menti.com. Go back to that. If you download it on your app store, iOS or Android, so just go to any of the app stores, look for menti.com. Once you download it, shouldn't take very long. It'll ask for a code in which you can all right. Some of our speakers are struggling with the link. Let me just quickly do this. If you can enter some of the information, I will just wait for that. So we've got some South Africans, Australians. Let me just quickly. Getting more people from Sudan, Ghana, Zimbabwe. We've got some international visitors, which is great. I think you're seeing on the picture what's showing up. Sorry, I'm just going to get this code so that we can get some of our speakers on board. So apologies for that. So let's go back. You can see we've got about 6 people who've put their names out. So please, I'm sure there are more. There are 25 of us. So I think more of us will be really great. So just let me make sure I'm giving it to everybody. All right. So I think our guests didn't quite get the link, so we'll wait for them to join. But we're going to start with, I think without Joseph Anna, who's a board member, who's going to do this, we're going to start with the first presenter, who's Joachim Stoneberg. Let me just move to the next few questions, and then we'll go there. So what is your profession? You should have seen that once you answered your country, you could actually add in your profession. So if you can add that in, get the juices flowing so you can see who's around the table today. GP. Some more. Wait for a few more people. Welcome, Carmel. Our guests are joining us quickly, so let me just make sure I've got everyone on board. Right, so we've got quite an array of people. We won't take any questions or hands yet. I think if you have any question, put it on the chat. So thank you for that. And Q&A we'll see just now. These will be, put it in chat if you have a problem with anything. So we've got quite a few people, interns, nurses, nurse tutor, health administrators. So thank you for that. Helga, I've sent you a link now by email. You should be able to get that now. That's all the participants, all the panelists. So let's move on. Time's running on. So let's just get the last 1 or 2 questions. As I mentioned to you, please add in your question. I think somebody's written there, South Africa. Just use this more to add in your Marcus answered. So just use that to put in questions proper. I think we can then move on, so don't forget that. So let's just mention that we're going to go through panel discussions. We'll have group feed discussions and then a group feedback. We'll see what the attendance is like and then make decisions, but it should be fun. So as an introduction, Joseph Anna, who I think hasn't quite joined us yet. Oh, there he is actually going to start. I'm going to just put up his slides and then we'll be ready to go. So let me do that and we can start with him. Okay. Joseph, over to you.
Okay, thank you. Good morning, good afternoon, and good day, everyone. And thanks for joining us for this meeting. I'm just trying to, thank you. So welcome, everyone. And I want to also welcome, I don't know how far
I've just had a very brief welcome to everyone. I haven't introduced our speakers, so you can proceed to introduce our speakers and then just give your opening remarks.
Okay, thank you. So we'll be having presentations from our very distinguished speakers. We'd have a presentation from Akiko Mida. She's a Japanese-Canadian health economist with over 30 years experience in international development. And she's held various positions with the World Bank, OECD, Asian Development Bank, UNICEF, and the UNDP, very widely experienced, and has managed several projects in health, labor, and education sectors, including girls' literacy. And she's earned a PhD in health economics from Johns Hopkins University and a master's in biochemistry and molecular biology, and a second master's of arts in the Middle Eastern studies from Harvard University. And she holds a BA in biochemistry from Princeton University. So that's Akiko Mida, one of our speakers. We'll also be hearing from Camille Martin. Dr. Camille Martin is the chair of Wonka Special Interest Group in Complexities in Health and co-chair of the North American Primary Care Research Group, committee of the Science of Family Medicine Complexity in Health Working Group. Camille is a consultant in Community Health Australia and an adjunct professor, associate professor in the Department of Medicine, Monash University. She is active in clinical general practice with a focus on chronic disease and illness, person-centered and complex unstable health journeys. She's an Australian medical graduate from the University of Queensland. She completed her master's in community medicine at the London School of Hygiene and Tropical Medicine, University of London, and she holds a PhD from the Australian National University. Welcome, Camille Martin. We'll also be listening to Dr. Joachim Stoneberg. He is a conjoint associate professor of general practice in the School of Medicine and Public Health, Faculty of Health and Medicine at the University of Newcastle, Australia. He's a graduate of Lübeck Medical School in Germany, where he also holds, completed his PhD. Since 1989, Joachim has worked in an urban group practice in the central coast of New South Wales. He will be speaking to us later. Our fourth speaker will be Helga Liszt. She's a lecturer at the University of Pretoria, Department of Occupational Therapy, and previously a lecturer at the University of KwaZulu-Natal Department of Occupational Therapy. She believes in a more just society, using partnerships for development, and she has research interests in food security, sustainability, occupational therapy, interpersonal education, and collaborative practice. She is currently completing a PhD program in public health. Welcome, Helga Liszt. So these are our speakers. I would set the ball rolling. Next slides, please. Essentially, I'm trying to move this. Yeah. We just give a brief look at AfroPHC development. AfroPHC comprises frontline workers of primary health care and supporters of primary health care who believe in using integrated, continuous, accountable, and people-centered team approach. AfroPHC, we are committed to achieving universal health coverage 2030 in Africa. We are committed to preventing the risk of the Africa UHC agenda becoming only hospital directed. It's very important, as far as we see it, that primary health care, which most observers and most practitioners have reckoned to be the anchor of any health system, Africa UHC should be centered in primary health care, which AfroPHC will provide a voice for such a policy within the African continent. Our mandate derives from the UN Universal Health Coverage Declaration of 2019, which is to strengthen PHC for universal health coverage. But we notice that that declaration is not, there's no specific address of the human resource for PHC services, whereas this is a major challenge that we face in the African continent. If the universal health coverage objective is going to be achieved, then the human resources for health must be taken seriously. And this is why this is one of the mandates that AfroPHC has given to itself. So I'll be talking on that. There's a health crisis in Africa, and the crisis means there's a risk that we may not achieve universal health coverage in this continent unless we address the human resources challenges. I'm reminded of a statement that a delegation of the British Medical Journal and the Nigerian Medical Forum UK made in 1995. And that statement was that no matter how beautiful the buildings or how sophisticated the equipment in a health facility, the most critical factor for quality healthcare delivery is the human resource for health. Their knowledge, their skills, their competence, attitude, and behavior. We neglect that to the peril of any objective that we want to achieve. So at the moment in Africa, across the continent, there's a severe shortage of human resources, recently exacerbated by the brain drain, the movement, massive movement of even the very few human resources for health that we have in the continent to greener pastures in the high-income countries. So that's a big challenge. And this, the burden that is placed on the staff that are left behind can be illustrated by one or two quotations from African countries. For instance, a nurse in Kenya said, you are left to carry out what you are supposed to do. The supervisor only comes when things have gone wrong, because they're quite often short-staffed in every shift that they run. Another quotation comes from a staff in South Africa, Durban, South Africa. We will just work and no one will see that these people are meeting their objectives because we are not being evaluated. Since I came here, no one came to me and asked me how good are these objectives? Which one did you meet? So the shortage of health workers in numbers, not to talk about their knowledge and their skills, is placing very heavy burden on the existing staff. Next slide. So the challenges, as I've said, is that there's a risk that we will not meet universal health coverage in the continent. No disease has laid bare the state of the continent's health, the weakness of the health systems in the continent, like the current pandemic that everybody is undergoing. The statistics are really troubling. We have severe shortage of staff, but we also have severe shortage of equipment. Next one, next slide. Next slide. Yes, it is true that the shortage of human resources for health is global, as reported by WHO, but it is worse in Africa. And as I said earlier on, the brain drain is making it even worse. Why do we have these shortages? Across the continent, in most countries, there are recruitment embargoes. So as people are retiring on age grounds, as there's attrition as a result of people death and illness, they're not being replaced. The few that are left, as I said before, are overworked and they burn out. In the meantime, the population is increasing. There's also the challenge that comes from the structural adjustment, economic challenges that the countries are facing, exacerbated by the pandemic. But even before the pandemic, this problem was existing. And then the very few that are left behind, they are inefficiently used. The distribution is skewed in most countries. And there is the lack of facility readiness. So the challenges include, apart from not having enough staff, we don't also have the tools for work. Next slide. The situation is exacerbated by staff being not appreciated or not valued. The training curriculum has remained very stagnant in most countries. This curriculum was shaped basically from the colonial experiences that we had. They have not been updated to meet the African context, to address the challenges that the graduates will meet when they get to our facilities. For instance, the in-service training quite often involves taking staff out of their facility to central positions for training. And that means that they are trained in the central location. By the time they get back to their facilities, they've literally forgotten most of what they have learned. And there is, in addition, poor harnessing of the strength in the multidisciplinary team. Various professions are still working in their own silos. So there's interprofessional disharmony, Some countries like Nigeria have enacted policies and laws on tax shifting, but is it actually happening in practice? So there is quite often a huge planning stroke implementation gap. Beautiful plans are designed, but when it comes to implementation, there's a failure. And because of the shortage of personnel, there is little supportive supervision, mentoring, or monitoring to encourage those who are working. What do we need to address this? Top of the list is the political will. We need to have the countries in Africa prioritize health as the most important of the sectors they want to address matters, beginning with adopting and implementing the Abuja Declaration of 2001. That declaration that urged every country in Africa to allocate at least 15% of the annual budget to health. From where what we could see in the literature, only probably a country like Rwanda has met that and on a consistent basis. We couldn't see evidence of any other country having met it. That shows lack of political will. And without political will, the rest cannot be done. Facility readiness, our facilities are run down. Part of the pull factor for brain drain is the lack of job satisfaction by the few health workers that we have. So they're moving. Yes, some of them might be moving purely for economic reasons, but a lot of them also move because of lack of job satisfaction within the continent. And we need to be able to improve competence. And we can't really do that without adopting more modern ways of training and retraining on-site in service and making sure that staff are appreciated, staff are motivated to be able to deliver the patient-centered care that we all desire. And without it, the universal health coverage will not be met. At least embargoes, there shouldn't actually be embargoes on staff recruitment, because whether we like it or not, there's going to be attrition from natural causes. And if we want the staff to function to capacity optimally, then we must address the issue of the numbers and how they're distributed. There must be recruitment and retention. Next slide. And every country should have, at this stage, in this 21st century, a policy of encouraging tax shifting and tax mixing, so that there will be interprofessional harmony, each member of the team, of the health team, appreciating the contribution by other members of the team. And by so doing, we'll have better outcomes, especially as the numbers are increasing. There needs to be some inter-country agreements so that it's easier for exchange of ideas, exchange of things that are working. And if you have challenges, you look across the border, you can actually might find examples of how those challenges can be met. So the countries within the Africa should need to be able to collaborate more than they're doing at the moment. Next one. Just an example, the picture there just illustrates the on-site training I was talking about, so that you don't take staff who are already diminished in number out of their facilities. If they're going to train, which is very important, they train within the facility. And this is taken from our implementation of PAC program for PHC in Nigeria. In conclusion, no matter how beautiful the buildings or how sophisticated the equipment in our facilities, the critical factor, the most critical factor for quality healthcare is the human resource for health. The knowledge, the skills, the competence, attitude and behavior, and their numbers. And African countries, we need to sort out our human resources for health challenges, beginning with investing in health, implementing Abuja, the 2001 financing mandate, and take quality of care out of the computer screens and off the bookshelves and place it at a point of care where it really belongs. Thank you. I want to acknowledge all my sources for this brief talk. Thank you very much.
Thank you, Prof. Joseph Anna. I think just to mention that all the slides will be available at the webpage, so don't stress, we'll provide that to you. Professor Anna, you can continue to introduce the panel, and I think I'll pull up the slides in the meanwhile.
Okay, so who's speaking next? Who is speaking next, please? Well,
it's me, I think.
You okay?
It's okay, Joachim. Right.
Let me just pull up your slides before. Kara?
Yes, Dr. Joachim is a conjoint associate professor of general practice in the School of Medicine and Public Health, Faculty of Health and Medicine at the University of Newcastle, Australia. Over to you, Dr. Stoneberg, please.
Can I have the first slide, please?
Just 2 seconds. Huh?
Sure. Let me start. Joseph, thanks for the kind introduction and thanks for the invitation to your group. It's very interesting to listen to you because you are essentially illustrating some of the systemic things I will allude to in my somewhat more theoretical basis to setting the scene. The theme really includes two systems. One is a system of primary healthcare teams, and the other system is that of universal healthcare coverage. And what you allude to by that is that you have the notion that systems do not exist in isolation. Systems are invariably always nested. So you have systems within systems within systems, and all of them have their own dynamics, their own rules, but they're interdependent. They cannot be separated from each other, and they influence each other quite greatly. Can I have the next slide, please? Just to reiterate, the term complex comes from the Latin word complexity and means nothing else but interwoven or interconnected. Next slide. The idea of complexity actually goes back much further than is normally seen. We have Bertalanffy and Wiener as the starting point in modern times, but about 200 years earlier, Humboldt really introduced the notion of system thinking by saying everything is connected with everything else. And if you do want to understand a phenomenon, you can only understand it if you do not lose sight of the whole. And Humboldt famously took every measurement and recorded it in its context. And he has shown validly how climate change is panning out. The shift of the tree zones has gone up 500 meters since his expedition to South America. Coming to some simple things that Joseph has essentially also alluded to. Systems are bounded. As I said, they exist within systems. And the interconnections lead to feedback, and feedback is the basis of the emergence of a system. The emergence is a phenomenon that is not predictable. One can perceive it, but you cannot exactly say the system will deliver this or the system will deliver something else. And most importantly, what's on the right-hand bottom is the fact that what is called the initial condition or the starting condition in which a system exists are exceedingly important in how it emerges over time. And very small differences at the beginning, and these differences may not be perceivable, can lead to quite marked differences over time. This is one of the things to keep in mind if you look at universal healthcare and primary care teams over a continent. While the principles of each of these systems remains the same, each of the systems needs to monitor and adjust according to where it is located, who is involved, and by responding to the changes that come along over time. Next slide, please. Looking at what is an organizational system, Russ Aikoff is probably one of the most famous researchers into organizations and change management. And he put it in very simple terms. The system is a whole that cannot be divided into parts, and the properties of the parts are not present, of the whole are not present in the parts. You can think about that in medical terms. If you look at yourself as a person, you are not defined by your parts, your organ systems. Your organ systems are necessary, but are completely different in their properties to you as a whole person. Next slide. If you look at what are the characteristics of a well-functioning organization from a complexity perspective, you start at the left-hand side of an organization needs to have a clearly defined purpose, essentially meaning we need to understand what is the reason for our existence. If we understand that, then we have to set ourselves some goals. And usually that cannot be much more than 5 at a time. That are the specific things you want to do. And to keep going, you need a third component, which is your core values. This is how essentially the glue that holds the organization together. And the values remain the same, even if the system and the environment shifts. And the 3 together are the basis of developing some simple rules or operational principles. That means you have a couple of statements that describe how people interact under changing conditions. Next slide. If one puts that into a metaphorical way of looking at the health system, this is an image that Camille and I, with another colleague, developed quite a few years ago. A vortex can only exist if it has a focal point. So that can be compared to what is the purpose of an organization. And from there, it emerges bottom up how the organization then is organized in different layers. So if you look at your health system, you have, in my view, the purpose of health is to look after people. And you do that in your local environment, in your local health center. but that local health center is situated in a community or in a region, and the regions together create the government level. If a health system is going to function in a seamlessly integrated way to deliver health to people, it is at every level that people have to keep the core purpose of the system at heart. While they're doing different things at different levels out of necessity, if they forget why they are doing it, you get a completely fragmented health system. As you are well aware from your own experiences, most health systems are rather fragmented, and depending on where you are, you always have a different agenda. Next slide. So if you look at it from a leadership perspective, we have essentially an image of what you see is the tip of the iceberg. What is actually happening in an organization is often hidden. And as the left-hand side shows, the leaders of an organization know about 4% of the problems. The people that do the work at the bottom know 100% of the problems, but are usually not asked. The leadership needs to engage everyone in a non-threatening way, encourage them to share their experiences, their concerns. That's part of the value proposition, and it's also part of the simple rules that need to be applied to a functioning organization. Next slide. This is an image of over time from the development of a private health, primary health system de novo in Nairobi, and this work has been done by Alice Narogo. I can't pronounce her name properly. Alice is a nurse by training, and she works for the Eastern Deanery AIDS Relief Program. And it started up with only a couple of people in '93. And the focus at that time, next slide, or click here rather, it started up with the aim of looking after dying patients from HIV and AIDS. And they organized a local small team of community health workers, nurses, and volunteer doctors to provide support rather than treatment. They went out into the community to look after people in their local environment. Click. By a few years down the track, they discovered that tuberculosis is a common core occurrence with HIV, and you need to treat that as well to make a difference. So they organized within their local community a sputum collection system and a technician that trained in one of the bigger hospitals to do the work in the local environment. Next click. And because it turned out from their experiences that people could not leave their area easily to get a sputum test done, and they then said, okay, if the people can't come to us, we go to the people, and they employed someone, bought them a bike, and they drove around to the different centers to collect the specimens, bring them back to the lab, and then in the afternoon go back with the results so that people could receive their results and their treatments accordingly. Next one. The system then expanded insofar as they recognize that food insecurity and hunger are a problem for people to comply with treatments. And they found Miller, who provided flour to the project, and every person who took their medications also got a portion of flour every week to help make it a success. Next one. And finally, they discovered that there is a need to provide support to people who have been orphaned, young people that have been abandoned, to get the emotional support to get over their losses of family members, to help with coming to terms with their own illness. Next. So next one. So here you see how over time the system has emerged and has developed, and it always has maintained the same focus, namely looking after people with HIV and AIDS in the local community. So you have a development, a de novo development of a primary healthcare system based on primary healthcare workers, largely community health workers that were recruited and trained from within the local community, and being then supported by trained nurses, by doctors, and building up, and later on also psychological support people. Next slide. So the key messages. Organizations are complex adaptive systems, and every complex adaptive system has to have a focus. And that is essentially why it exists. What is a purpose? Without maintaining focus, an organization cannot sustain itself. And I think that the Vortex model offers a useful reminder to everyone involved in the primary care system or in the health system at large, to not lose focus on what it all is about. Next one. I have some references for you. You can pick up from the slides later on, and it shows you all the references to the models I have shown you. Thank you.
Well, thank you very much, Joachim Stoneberg. Thank you very much for that presentation and the insights that you've given to us. I just will focus on those messages. Organizations are complex, adaptive systems. And thank you for highlighting the fact that we need to have a core focus. Any system that doesn't have focus cannot expect to meet its goals or objectives. And for the examples that you've given to illustrate the Vortex, the model, in bringing this in the operational area. Thank you very much. Now, the next we'll be listening to Akiko Mida. And Akiko Mida is a Japanese-Canadian health economist with over 30 years of experience in international development in over 40 countries in Middle East and North Africa, Central Asia, South and Southeast Asia, and Europe. She's very extensively experienced. Akiko, please, over to you for your presentation.
Great. Thank you very much. I hope you can hear me. Good. It's a great pleasure to present to you, and thank you very much to the organizers and for the participants. I'd like to follow up on Joachim's excellent presentation. Oh, can you, okay, that's okay. You can keep it to the first, sorry. It's okay, you can go to the next slide. Thank you. What I would like to do is to follow up on the previous presentation, continuing a discussion on what do we mean by complexities, a little bit more of a different way of conceptualizing complexities, but particularly from the primary healthcare perspective, and to look at why is primary healthcare becoming more complex? Why do we suddenly talk about complexity? In this case, the previous speaker has spoken about the whole healthcare system, not just primary care, but I'd like to look at it from both the healthcare system and also from the population and patient environment, because there is an interaction going on between the health system and the population at large, which is complex, and we need to be able to get a handle on that, and briefly talk about how we can describe and model complexities. This is the overall progression of my talk. So if I could start with the next slide, please. Thank you. So in primary healthcare context, what do we mean by complexities? Well, Joachim talked about the vortex approach, but here I give a slightly different slice of that. In the left-hand side, I talk about the segmented approach is where the primary healthcare has become. It has tried to address many different aspects of healthcare needs. And so we have typically, for example, a look at the child and infants and children. So we talk about child immunization, child diarrhea, and so forth, and focus on that as one important aspect. I used to work for UNICEF. So of course, there are a lot of very important projects that deal with child healthcare, which is part of UNICEF's focus. The other aspect of the segment is the women as particularly as mothers in the Africa region. Maternal reproductive health gets a lot of attention. We must not forget menopause, postmenopausal for the elderly and aging women who have their own set of problems, which may be neglected, I find, in some countries where the issues of youth and younger women are predominantly the focus. And then, of course, in where I come from, like in Canada and Japan, it's the chronic diseases of the elderly that takes a lot of attention. So what's happened in primary healthcare, despite the fact that we talk about it being comprehensive or universal, it does tend to become segmented by population groups as well as by expertise, pediatricians versus geriatrics and so forth. So the challenge we have in primary healthcare as in elsewhere is how do we then move from that to a more integrated approach where we deal with the whole persons, the whole families, the person-centered care approach, where we also look at not just the disease per se, but the social environment, the social determinants. We talk about public health, which is different from private or individual health. At the same time, we have technology that is coming that has to be brought in and integrated, which can be costly, but which can also be very powerful tools for being effective in a very resource poor regions. And altogether, we're moving towards the concept of integrated care. And this is indeed a situation where we are creating the need to deal with complexities. So previously, we've tended to address complexities by breaking things down, making it simple algorithms as a way to address complex problems. And especially as Joseph discussed, where we have resource poor or where skilled workers are not available, it does help practically to break things down and to try to address them. And certainly in organizations like UNICEF, they have been enormously successful in addressing large problems like immunizations, so forth, by making things simpler and focused. So we don't want to take that away, but how do we then take this together and take a more comprehensive, integrated approach in a complex environment? Next slide. So first, I mentioned that it's not just complexity in the healthcare system, but we have increasing complexity in the social environment, the population at large. So in my country, as in Japan, we have a breakdown of the extended family connections and community. And this has been going on for a long time. So in a way, we are asking the care system, not just healthcare, but also long-term care and social care, to look after this, to look after the problems and the ills of an entire society. So it's not just fixing a little bit of disease here and there, but increasingly we're being asked to deal with the breakdown in the social fabric. In Africa, this is also the same. We have migration, internal migration, urbanization, conflicts. This is certainly breaking down what used to be there, the social caring environment, which is disappearing in many places. And this leads to social isolation, loneliness amongst both young and old, which has huge implications on your health as well as your social well-being. And of course, we've talked a lot about growing inequities and marginalization of different population groups. Despite all the efforts to deal with reducing poverty, we have not really addressed this issue of marginalization and dealing with the needs of the vulnerable groups. So this is the context which is becoming complex in the society. Next slide. Joseph has already spoken a bit about the increasing complexity in the healthcare system. A major challenge we all face is the rapid advances in technology, which is changing the way we deal with and provide care. But we also have a growing new categories of health professionals. It's not just your traditional doctors and nurses. Increasingly, we have community care workers, social workers, medical anthropologists. We need to work with housing, with social and other types of professionals. That makes it very complex to work in a healthcare system, which can no longer be dealt with by a limited number of professionals. And this means on the health worker part, we really have to hone our interpersonal skills and deal with the emotional context and deal with this better. And the existing healthcare training systems may not address this adequately. We've also have to train our healthcare workers in adaptive problem solving in a team setting, not just within the usual medical teams, but in teams that may include the police, the security system, the immigration authorities, the housing authorities, housing groups. So this is becoming quite complex in bringing people who come from different vortices, the vortex. You have different vortices that have to somehow be brought together and not be working as separate silos. So this is the increasing complexity in the healthcare system itself. Next slide. Joachim has already done a great job in introducing the notion of complexities in but I'd like to add a little bit more in our notion of complexities. It is about connectedness. It is more than just complications and many, many factors. So it's more than just dealing with multiple factors at the same time and juggling it. It is the fact that because they're connected and they interact in a certain way, that we end up with a system that produces what is called an emergent behavior, a behavior that is not easy, that cannot be predicted ahead of time because it arises from this very complex interactions amongst the individuals. And so here we have a picture of the starling birds that form this very complex behavior that looks like the group of the flock of birds look like an organism itself. And that behavior is emerging from there isn't a central big starling brother who is saying, okay, you turn left and you turn right, and somehow creating these beautiful patterns. In fact, these birds are independently following three simple rules of the game, as it were. And they have to make sure that they remain separated at least so many feet apart, that they are behaviorally trying to avoid each other from crashing, but they're also trying to align to the big group. They try to take the average of the center of the gravity of the group and want to move in that direction. And they want to also follow the average direction that all the other birds are following. So these 3 simple rules result in this very complex behavior. So they look like a giant animal or a bird, and hopefully they want to scare away their predator birds like eagles and so forth. So this is an example of an emergent behavior, which is important to understand. And so I want to give you some examples of what we mean by that emergent behavior in the primary healthcare setting. So next slide, please. So here, I'm giving you an example of an emergent behavior related to vaccine hesitancy. And this is in a population health environment. What we're discovering, and through not just COVID, but all of you must have dealt with this issue of vaccine hesitancy in some form. It requires not just to say we have to just train the health workers and get them to go out there and just vaccinate. Obviously, with vaccine hesitancies, we've learned as public health specialists that we have to understand the emergent behavior of the population we deal with. And one of the helpful new technology tools is the social media, which has been used to model how vaccine hesitancy emerges from a population. And this illustration I give is a Facebook analysis of 197 anti-vaccination people who post on Facebook regularly, and to see how people around them behave around that. And what you start to see is there are identifiable subgroups amongst these anti-vaxxers, and that what kind of arguments are being put forward. It's the lack of trust, you know, the concerns about safety, about a conspiracy theory. So what you start to see in these emergent behaviors, there are certain few number of influencers who then lead to this explosion of mistrust and bad information going around. And but there are connections, and there are ways in which through this particular context, there was a sense that if you deal with these certain influencers and groups, that you can identify and target and give the right messages that would resonate with these people who may be on the cusp or not really that deeply anti-vaccine, but are influenced by these groups, and they can more easily be brought back into the fold, as it were. So this is an example of how we deal with this emergent behavior in a context of this social rumor mill and spread of misinformation that needs to be addressed. So as we go towards healthcare universality, we'll increasingly have to understand the social sentiments, the emotional environment, and how do we deal with that. Other examples besides vaccine hesitancy, we've seen about mask wearing and how the mistrust of the authority leads to mask wearing being a symbol of the authoritarian rule. So how that, then this emotional explosion, how do we control that? It's not going to be controlled by just the healthcare worker saying, you must do this. Obviously, you're representing the authority. So that's another example. I think another very terrible example is what happened during the Ebola crisis, with the lack of trust of the healthcare workers, you know, wearing these protections that they look like aliens coming from the space. And sadly, many of them were killed in a context when the communities didn't trust them, and they were trying to change the behavior, for example, of the way you bury your dead. And that led to very, very sad situations. So that is understanding the social sentiments, the fear. How do you deal with that? In countries like US and Canada, there's the opioid crisis because of workers losing their sense of purpose, feeling lost, and then the availability of these opioids easily prescribed led to an explosion of opioid crisis in the US and Canada. And so again, dealing with that is a complex system, understanding the complex social behavior, as well as how to approach them in a way that persuades, changes sentiments, and so forth. So this is an example of this sort of social sentiments and how we deal with that being a complex problem we have to deal with it through complex systems analysis. Next slide, please. I wanted to give one more example, more at the micro level, because the previous one we took at the sort of big social level. But here, I wanted to talk to you about the example from Ethiopia. Many of you may know about the health extension program, where because of this lack of doctors and nurses, the Ethiopian health ministry took a very ambitious and very brave move towards expanding and training the role of health extension workers who are secondary school graduates. They're mostly women, and to train them in different primary healthcare interventions that go from family health services, as you can see in that upper left-hand corner, disease prevention, trained in not just one, but various different disease prevention, hygiene and environment and sanitation, how to build toilets and keep the communities clean, and of course, the overall health education and communication strategy. So these health extension workers are not doctors, they're not university graduates, but they were trained and given the tools and knowledge to deal with the multiple factors, the complexity of their own community. And overall, this, and they were trained in massive numbers. And this has resulted in some significant achievements in terms of maternal child health, communicable diseases, improved hygiene, sanitation, improvements in the knowledge and health-seeking behavior. So this is cited as a great success. And yet, what are some of the big challenges on the healthcare side that had not been anticipated? I'll give you two examples. One is that whilst all these workers were trained in these 7 broad areas, and they were asked to work with their communities on that, what had happened is that in many cases, they tended to then focus on just one task. And interesting, it was the toilet and hygiene task that somehow became very, very prominent. So to the neglect of all the others, that became the focus, which was important. But what in doing some more qualitative research analysis, what one found was that these women were perhaps in their primary and secondary education not given enough training in planning and multitasking. So this is something that we take for granted often, that you just go out there and do these tasks once you're trained. Well, actually, the skill of stepping back and planning and knowing yourself, how you tend to become obsessed and do things that we like. How do we then train ourselves to then pay attention to the others? It's in some way somehow basic, but in terms of discipline, it does take practice. That aspect of the training, which had been assumed to have been done in their earlier education, had not happened. And so often we ended up with, instead of multiple factor project progression, we ended up with one track. And so that was something that came out and emerged as a need for a training that requires not subject matter, but how do you organize work? And that was something that I believe the training is trying to address now. The other emergent aspect, and this refers to what Joseph was saying, why are you losing your health workers? Well, the other aspect that emerged was that there was not enough attention paid to the career development of these health extension workers. And their community level is, okay, great, we have all these enormous number of women who are trained. Well, guess what happens? People are not just robots. Once they get empowered, they become powerful and they start to clamor for their own career. What's next? They're not going to just stay as a health extension worker. Many of them wanted more training, maybe become nurses and doctors. So the career pathway hadn't been adequately thought through. So this is something that emerged. So that again, this adaptive part, if you just stayed at the health extension program, you will lose your workers. You'll have the brain drain, or they'll go into other things. Something similar is happening in India with their ASHA, their own community health workers had become in a way of movement, that they've started to become like a union. And so they've gotten some negative response from the healthcare system because they've seen as difficult troublemakers. They're not working with the other healthcare workers because they've unionized. Well, unionization, labor movements, this is part of human behavior. So as healthcare system, you've got to deal with it, but you hadn't thought through. So that's another complexity in a system where we have to think about not just training them and trying to retain them, but they're human beings with ambitions, with complex behavioral movements that have to be addressed. So that's another example. So next slide, please. So I just wanted to leave this slide with you. I won't go into any details, but how do we model? We've described complex behavior, but how do we model? It's impossible because it's complex. Well, what is wonderful with the technology is that there are now programs like NetLogo that can take complex behavior of these different agents and help you to program them and describe them and test them out. You've got, for example, you have a NetLogo model of COVID-19 virus spread. So you model, you could put 1,000, 10,000 agents like that and give one person infected, and let's see how the infection spreads. You can change the sentiments, trusting, not trusting authorities, mask wearing. So you could start to layer in these behavior aspects and see what emergent behavior comes out. So in a word, there are models that help you to design and test out certain ways, let emergent behavior come out. And I think that these are going to become increasingly important in how we try to predict and understand complex behavior. So I just put this there as something to think about for future training in programs like NetLogo. It's a lot of fun too, because you can see that it has a visually very compelling ways of describing behavior. So final slide, next slide. So I just wanted to capture the key points, key messages. As we said, complexity is more than just a mere collection of multiple agents and factors. We need to be really mindful of the details of the individual interactions from their diverse points of view. We have heterogeneity, we have people with different ambitions, so forth. So we do need to be both aware of and respectful and understanding of that micro level, local level, patient-doctor level interactions, the emotional aspects as well as the other aspects of behavior. But at the same time, as Joachim said, we need to be able to step back and observe the larger emergent pattern that comes out of these individual interactions. How do these influence and end up in a population level or a community level, how these interactions end up with these emergent behavior. So being able to go from the micro level, step back to the macro level, and it's this being able to hold this together at the same time is some of the skills required to understanding, describing, and developing adaptive solutions to complex problems. Final slide, please. Thank you for your attention. And my email address is there.
Well, thank you very much, Akiko, for that. Actually, very brilliant follow on what the introduction to complexity is. The message is very clear that we need to be mindful of the various interactions that happen. And we need to observe and notice the emerging complexities that emerge from the initial complexity. Thank you very much for that. I hope we are all taking note of our questions for the speakers for when the questions and answer session comes. Next, we'll be listening to Dr. Camille Martin. Camille Martin is the chair of Wonka Special Interest Group in Complexities in Health and the co-chair of the North American Primary Care Research Group, Committee of Science of Family Medicine Complexity in Health Working Group. Camille, you're welcome. Let's listen to you now. Thank you.
Thank you very much. I'm going to take a different approach to these very wonderful presentations we've had previously, and talk about my experiences in primary health transition funds or primary health transition movements in predominantly Canada, but Australia, Ireland, and the UK. I just want to talk about my experiences. So, and I will then talk about a case study in the Inuit regions of Canada. The Inuit are the Indigenous people way to the north of Canada. There are several groups of them. They're in different provinces and mostly don't speak English. To talk about my experiences in working with them and their evaluation of the Aboriginal Health Transition Fund, which was part of the Canadian Transition Fund. And then I wanted to, on the basis of my experience, just touch on a framework for making sense of evaluation in these primary care systems. So what I've got here is, on this slide, is sort of the orthodoxy of primary care, extended primary health care, primary care or selective primary health care, and comprehensive primary health care. And the primary care model was a model of general practice that came from the UK post-World War II, or even earlier. It was then recognised that there was a need to sort of broaden. And then there was the development with Alma Ata of the notion of comprehensive primary health care. I'll move on to the next slide. When we talk about primary health care, since Alma Ata, there have been an enormous literature on primary health care. And primary health care as a construct sounds complex actually, but it is very complex, and the literature is complex. And there are a lot of different concepts of the nature of primary health care in the literature. And it's actually, this was you can look at this later, but this was a thematic analysis of primary health care literature that was done by my colleague when I was in Canada in the about 2006. Next one. So we've talked about, so in the goal of achieving universal health care and primary health care, and has been said before, but I'm putting it in a sort of a more policy framework, there's the individual level, unique individuals in the context of family and dynamic environments. These individuals are adaptable and learning agents with the capacity to change. We always think of the population as being something we have to do things to, but in fact, the population and people are partners with us because they're learning and they're adaptable and they can lead. That there are different stages of health journey, just like there's different stages of the transition to primary health care or the development of primary health care and universal health care in different countries. There's also different stages of health journey for individuals and practitioners who have variable strengths and interests, as we've heard previously. At a health system level, there's a heterogeneity of groups, communities, and this necessitates diverse and adaptable services. Africa, I think, probably takes the world lead in this, but there's a heterogeneity of cultures, capacity, motivations in providers and patients. In any country, in any group, there's this heterogeneity, but I think Africa probably is world leading in that. There are multiple layers of activities, and one thing with a system, just like an individual, there's potential for continuous evolution and improvement. So the notion that somehow or other we failed, or something failed, or we did something, I think is probably not a helpful way of looking at the development of primary healthcare, because every country, I mean, no country has achieved this ideal of primary healthcare, and every country is somewhere on the journey. There's always potential for continuous evolution and improvement. So it's a sort of a positive message. Next, thanks. Next slide. So this is just, again, it's from a paper that was written, and it just talks a bit more about the, in more detail. So I won't go into it, but it's just really expanding on the points that I made previously. So we'll move on to the next slide. Okay, so again, this is just a different way of framing what other speakers have presented earlier. That if you're looking at this at a sort of a high level perspective, that every individual has their own health is determined by a combination of these factors. And people's perception of their health determines often help seeking and engagement in health services. So it's important that we have this at the center of the vortex, the individual and their family and community. Next. Now this is a sort of trying to tease out, you know, where does primary health care begin and end? Because everything that we've heard about the complexities, there's actually no boundary to primary health care. You know, we have to be doing toilet systems and you know, it's food security. And so one of the issues about primary health care and this universal health care is, where are the boundaries of this system? So there's multiple interconnected systems, but I think it's really important to think that there may actually be boundaries, that you are actually going to be training a range of healthcare providers to work in teams, and what are the boundaries that you expect of them? Because if you have such unlimited boundaries, they're never going to they're going to always be failing. You have to think of the capacity and the boundary of what the expectations are. As much as you want to have emergence from the bottom, you still have to think that what is this system? I mean, the system is going to be porous, and it's going to be, it's going to move, and it's going to be different. But there is a need to actually think about what, in the context of primary care, selective primary care, and the vision of universal primary healthcare that has no boundaries, that addresses everything that's possible in health. There is a need for some, in a sense, some sense of constraints on what you're expecting people to do, because otherwise they won't achieve. And this is a sort of a map we did in the Canadian situation. Next, please. So one of the tasks that we had to do, or we were given to do as a consultant to do, was to look at unfinished business in primary healthcare. So in Canada, they had the transition fund, and then they put a lot of money into people working in teams, developing new models, training new type of workers, you know, testing out, evaluating. But in the end, at the end of all that, there's still unfinished business in primary healthcare. And an ideal would be go forward was the emergence of local models with transdisciplinary providers networking in a participatory system that will produce the best outcomes for the population of a particular community. So that would be, you know, sort of where we like to be heading. And while valuing high-level principles and values promotes local governments, high-level principles and values promote local governance, allowing for flexibility to adapt operation to different local settings. So this is where we'd like to be. And sometimes we're there, sometimes we're not. Next, please. So now I'm going to talk about the experience of one piece of work I was involved in. And so while we had the Pan-Canadian Primary Healthcare Transition Fund to transform to primary healthcare, we had then the Aboriginal Healthcare Transition Fund. And as you know, or you may not know, Canada has First Nations people, Métis people, and the Inuit. And the Inuit are the most, the poorest, the most fragmented, the least educated, and actually, because they're living up and having a very healthy lifestyle before smoking, they're probably the healthiest, even though they'll be suffering the consequences of global warming. So one of the problems there was that antenatal care or prenatal care was that there were no hospitals in that area. So despite the fact that policy indicates that people should have antenatal or prenatal care, XYZ, it was actually, and they set out to do that, it was actually frightening women because they thought that they would have to go away from their families to deliver in a hospital. So that was the problem. So there was, in fact, the well-intended policy actually resulted in less attendance for antenatal care. There was little respect for the Inuit doulas, the Inuit midwives. And in fact, they were fighting amongst the teams of midwives, nurses, who does what, the obstetricians, the GPs. So in fact, the services were, despite having this universal healthcare and this wonderful policy and funds to improve things, actually things had got worse. So what was clear was programs initially designed with First Nations in mind and mainstream Canadians who are multicultural and et cetera, but wealthy, did not fit well with Inuit needs and environments. So what was one of the problems was that there was this incredible fragmentation despite having teams. And there was a need to integrate regional, national, Inuit and Western perspectives and other polarities in these complex local environments, as well as the need for adaptive local services. Next, please. So one of the projects was the Paktuit, which is an effective knowledge network with a system to promote information exchange and cultural safety for women of childbearing age, their eldest partners, and their community and prenatal care. So what emerged was that it isn't just enough to have providers, to have teams. You actually need to have another layer of networking, of someone who connects all these people up, who can talk to different provider groups, can talk to maybe policymakers at a local or regional level, in order that we have this effective knowledge networks with a system to explain information exchange. Next, please. So this was an emergent solution. This was a new solution that came from the Inuit, that from the lack of readiness for change in local communities and dealing with multi-layered, multi-jurisdictional and multi-agent organisations that were often working to their internal agenda with lip service to change, that's when you've already got these services in place, they may actually not want to change. And so what emerged was the ongoing deployment of regional engagement coordinators who are meso-level agents who work with the ground teams and communities, and also across that intersectoral bridge when needed. And the generic worker who works with the multidisciplinary team. So you've already been talking about the community health worker or the health extension worker. So that was what emerged from the Inuit. There was a need to have actually someone who did some of this connecting across different systems, but was close enough to the ground. So a meso-level agent. Next one, thank you. So this is what came up. Regional engagement coordinators who network with macro and micro level and across sectors. Interdisciplinary, multidisciplinary, disciplinary-based nursing, midwives, GPs and obstetricians, and transdisciplinary, who would work with any of the disciplines. What we did was we had workshops of all these providers, and particularly the professionals, and hashed out, you know, this is in the Inuit context, hashed out some of the tensions and contradictions with the help of the regional engagement coordinators, setting up actually a network. Next. So just an overview, currently reforms in primary healthcare that are driven by goals of standardisation of structure, process, agency, according to the best model of PHC delivery. So one of the questions in Canada all the time, and maybe internationally, is what is the best model of primary healthcare delivery? You know, how many doctors, how many nurses, how many community extension workers, how many X, Y, Z do we need per population, and how should they best be combined? So in the idea of universal healthcare, there's an idea that maybe there's some standardization that requires equality, but it's not necessarily equity. A complex system approach looks at models with providers networking in a local system that will provide the best outcome for that particular community, etc. So the next one, thanks. Moving on to evaluation, very much the experience in Canada and Australia and elsewhere was the idea that there was really a need to have this macro level, meso level and micro level questions. However, often the evaluation is at micro level. That is, who are the providers, the volume type, quantities of services that are provided, and their immediate outcomes. And little evaluation of the meso level, which are these systems, and the little attention to the meso level connections amongst systems, as well as at the micro level, the funding and other and policy. Next. So in evaluation, I'm bringing in a little tool here. This is the Cynefin framework. And in a complex system, there are actually some things that are actually quite clear and standard. And it's quite reasonable to have performance indicators that are warning lights. As long as performance indicators do not are not the everything about the system, they're treated as indicators, the performance metrics, you know, number of cases of XYZ treated, you know, number vaccinated, etc. So performance indicators can be very helpful, and the number, you know, the retention of team members, etc. And then at the middle level, there's the systemetric analytic system, you know, what Akiko was talking about, the modeling of the systems and modeling of teams and outcomes, and there's no limit to it. But at the complex level, and Helga's going to be talking more about this, is how do you make sense of what is complex, which is what a lot of, or most of what primary care is, primary health care, and has been talked about previously. And there's sense making, stories, qualitative evaluation, triangulation. And that's important that is given the priority, and balances the performance indicators and the systemetric analytics. So that's a tool for looking at your evaluation approaches. Next. And this tool, it might seem that, you know, there are metrics or it's different levels, but actually there's multiple layers of sense making, and this is a sort of vortex model, but evaluation really needs to take place at all levels, and it needs to be integrated. You can't have one without the other, and you need all of those dimensions apply, mentioned previously. Next. Okay, so my key message is that one size does not fit all. Multi-level system approaches are needed. Ongoing learning and reconciling existing culture and efforts with new primary care. We're never going to be there. This approach, the primary healthcare approach, will never be complete, and systems will constantly need to be changed. And we should, you know, feel proud of what we achieve when we achieve it, and keep going. Thank you.
Wow. Thank you very much, Dr. Camille Martin, for that very brilliant presentation, and particularly the messages you've left behind. One of them, one size does not fit all. I think that's a good message for all of us to carry along, especially when we are comparing systems in the global north and the global south. Thank you very much. Now we'll listen to the fourth speaker, Helga Liszt. She's a lecturer at the University of Pretoria, Department of Occupational Therapy, and previously a lecturer at the University of KwaZulu-Natal, Department of Occupational Therapy. Over to you, Helga Liszt, please carry on. For want of time, just carry on.
Thank you so much. Can everyone hear and see me? Thank you for the introduction. What I'm hoping to illustrate today is using two cases, and through that explaining what the other wonderful panelists have already gone into detail about, so that we can use names and faces in aiding these learnings. Next slide, please. At the starting point, I just want to go to this ancient wisdom, namely, we can't teach what we don't know, and we can't lead where we don't go. I started my PhD in food security of women living with HIV and disability in vulnerable households a number of years ago. I had moved to Pretoria, having gotten married, and started sourcing participants for my study to be able to collect the data using a life history methodology in Mamelodi, a peri-urban community. Although I had studied at the University of Pretoria for my undergraduate degree that had been over 10 years before, I never worked in Mamelodi, and I therefore entered the community without an understanding or knowing the connections or services that exist. Working through the primary healthcare services, and specifically the community health workers, I asked whether they could help with finding participants who fulfilled my inclusion criteria. One of these was Maria, who I was told had a disability. Next slide, please. When I met her, she did not appear to have an obvious disability. Yes, she had been in a pedestrian accident a number of years before and had some level of hip pain, but she was otherwise fully functional. But what became very apparent during our first conversation was that she was showing signs of severe depression and suicidal thoughts. What emerged was a woman who was very concerned about her 3 sons who all had substance use disorder, her daughter who was struggling with her schooling, her mother who had an illness, her lack of income and access to sustainable food sources, thus needing to go to an area in the community where refuse was being left to pick up a type of spinach that was growing there for her meals. Her ex-husband, who was having extramarital relations after the birth of one of her children, had been poisoned by that partner and died. She was tired and she cried all the time. I harbored an initial fear of her sons when visiting her. Maria had said that they would steal from her in order to purchase the nyope. And I realized that no matter what I had applied for in my ethics application, this could not remain research without intervention. I referred and took her to be seen by the psychiatrist at the local community health centre to prescribe the necessary medication. I was told through the networks that there was some kind of a program that was available for people using substances that however cost 500 Rand per person and thus being entirely unaffordable for this family who needed 3 people to be receiving the opioid substitution therapy. And I had difficulties trying to find out where this program was and who the people were that were involved. Over time, I however started working at the University of Pretoria and supervising the students who were conducting their service learning fieldwork in Mamelodi on their community block. And in this way, I made connections with the healthcare services from the other side, to the community-orientated primary care research unit from the family medicine department with its community-orientated substance use program, or COSUP. And I then learned about the harm reduction approach they advocated. I also started understanding substance use differently and would go to the Mashangwana household to try and encourage Maria's sons to participate in the program. Next slide, please. On one of those days, when I was in Mamelodi for work purposes, I decided to visit Maria to see how she was doing. Upon arrival, it became very clear that she was worried about one of her sons, Alex, who was very sick. She said he'd been admitted to hospital for edema, but had signed an RHT form insisting on being discharged because his cravings had become so bad. I asked to see the medication, which indicated he was receiving something for cardiac failure. I didn't know what was going on. I telephoned a professor lecturing in family medicine, asked what I could do, and he said I should take him to the emergency unit at Steve Biko, which is a tertiary hospital, academic hospital. Not wanting the same mistake to happen, I said to the mother, we need to purchase Nyorpa so that Alex can take it along and that he can smoke it if he requires it in the hospital and that he won't discharge himself again. The Nyorpa sellers did not want to sell her the drugs with me being outside the home there. And I therefore in my car went in search of the sister to try and find her so that she could accompany me to the hospital, because Maria, the mother, did not want to leave her home where the other 2 sons were left because she was concerned that they would steal things from her house in order to purchase their drugs. We eventually left, Alex, myself, Karabu, Samna Yorpa, and went to the emergency unit where the staff became frustrated with my insistence on them seeing Alex and that there was something wrong. Turns out it was valid. Alex had severe microcritic anemia, tachycardia of 110, as you can see there on his report, anemia HB2, respiratory bronchial bleeding, and bilateral inspiratory crackles. He was transfused 3 pints of RCC. And only after 2 weeks, when we thought that he actually had a chronic condition and was potentially going to die, he told the doctor that he had had severe stomach pain, had been to see a traditional healer, and following the prescribed medication from the traditional healer, had vomited a lot of blood. Next slide, please. He was treated successfully, and the 3 brothers did try and attend the COSUP program. As you can see, that is at the Lusaka site where our students work with many of the COSUP clients, looking at things, for example, developing trust with family members, which is so very needed. Unfortunately, when I visited them last year, a while after the initial COVID lockdown, and to see how they were all doing, excitedly greeting Alex and saying, you almost died and I'm so glad you're alive. How are the rest of you? He's like, yes, I'm well, but poor, my other brother has passed away. The reason is still unknown. Key problem areas. Next slide, please. This short illustration is but a snippet from a much longer, bigger and more dynamic, interchanging story. But key learnings are that we cannot approach a person with only a certain lens, as I had, for example, food security, HIV, and disability, but that things are so much more complex in the household. As you can see here, the brothers attending the COSUP program with their difficulties of substance misuse, unemployment, boredom, and lack of trust. Next slide, please. Relationships are complex, and community health worker training needs to use examples to illustrate complexity and dynamic movements. And especially when relationships change, as had with Maria, who at various points did not want to have contact with his sons, and then again did want to, and is now mourning the loss of one of them. We cannot separate health, education, economic security, well-being, social dynamics, housing, etc. All of these sectors have to work together for overall household and community well-being. And when the community's understanding of available resources are limited and not clear, and the service providers do not understand the culture and the context, there are mismatches in the available avenues, and resources are not used in the most effective and sustainable way, of which, as we know, resources are very limited. Next slide, please. In this intervention or this example, I therefore propose that healthcare teams are aware and understand that households are dynamics in our relationships and needs do change, that any form of intervention requires community-based understanding of resources, assets, services, and connections, and that we have to use household and community networks in finding these solutions. An intervention is long-term. It's not just a once-off thing. The story keeps on unfolding. And thus, as you might notice, I'm still not finished with my PhD because the story keeps on changing and I keep on thinking I need this to add it in before I actually write it up. Seems sometimes I'll be collecting the data forever. Skills training of community health workers should address households in as broad an aspect as possible. Like here, we cannot just justify providing food parcels as an intervention for food insecurity when there is the risk that the children will continue to sell this food to obtain money for substances. Intersectoral collaboration needs to be achieved through clear and thorough communication, and we need to work at this. And advocacy, knowledge, and translation of ownership of the situation by the household should also be facilitated. And of course, we have to put a much greater focus on prevention. Next slide, please. In my next case study is that of my own, my maiden name being Koch, my sister having returned from the UK 5 years ago because of my father's dementia and my mother's caregiver fatigue. My parents had lived in KwaZulu-Natal all their lives, but they moved to live in Cape Town for greater family support. My sister and her husband added another 2 children to their existing son and daughter. And there you can see the other 2 pictures of that of my family and I and my brother and his wife. Next slide, please. On the 26th of May this year, I received a phone call from my sister that my father had fainted and fallen and had been admitted to emergency. He was transferred to another hospital because of the lack of beds in ICU due to COVID. He was diagnosed with pneumonia and underwent further tests, initially being seen as COVID negative. I flew down at 6 the next morning to support the family. Although this context is within the South African private healthcare setting, my father's initial care for his normal pressure hydrocephalus, hearing loss, visual problems, and vascular dementia had been treated in the public healthcare sector. I believe that there are some important lessons also to share from the Koch household because of what transpired from the original pneumonia over the next 8.5 weeks involved him developing COVID-19, being diagnosed with a heart block and requiring the insertion of a pacemaker, the observance of an unstable T9 compression fracture and a burst and chance fracture at T12 requiring surgical intervention, but not possible because of a new hospital-acquired infection and lack of ventilators in the hospital. Regression of his dementia, confusion, reduction of motivation to live, impulsivity, and a high risk of spinal injury, amongst others. Poor communication between hospital and specialist staff, and on numerous occasions, my spouse and myself spending 6 hours on the telephone a day trying to coordinate my father's care. Next slide, please. The situation was compounded by what had happened 6 weeks before, namely my sister's husband, who is featured there, committing suicide. Next, please. A family dealing with acute grief, loss, and confusion, together with the household needs of 2 very young children, namely Clara, who at the time was 2, and Erin, 6 months. Additionally, my mother and aunt, who had been visiting the household to provide support, contacted COVID during the one night my father had returned home after his first 6 nights and before all the additional complexities had been identified and come to the forefront. I was fighting to keep my father alive through the motivation he held by needing to be there for his 4 grandchildren who had lost their father, which involved trying to do online lung exercises. Next slide, please. Numerous times during the day, knowing that the hospital staff were unable to do more with the high number of hospital admissions, the hospital going into lockdown, and thus no additional access being available. trying to create opportunities for his loved ones to chat with him as much as was possible during the day, dropping off letters, cards, photos, and snacks as messages from home. When one is engaging with healthcare providers, next slide, please, from the side of a receiver, as I was now, you realize that people do not know what is happening behind the scene. That, as you can see in that first picture, my sister, who was sitting in a hospital cafeteria working because of her need to earn and not having a permanent job and the loss of the income of her husband, on the first day that my father had fallen, receiving a message from her eldest daughter's class teacher that she wanted to do an oral on the children's dad's favorite snack for Father's Day. That the need for personal connection and incorporating the spiritual is what ultimately can ensure someone's will to life. So more so than sometimes the medication that they are receiving. That when someone is discharged without proper discharge planning and being aware of the household, if the family cannot yet cope, one cannot just look at the functional outcomes of the person who was originally admitted to the injury. You have to look at the household. It became very clear that unfortunately, even the private sector does not offer care coordination and follow through. There's no recognition of the importance of the expertise of the family, and that details are often important to be shared so that they can be processed. I remember speaking to doctors and asking, please tell me the exact details so that we can pray for it. We've got a prayer team. Everyone is praying, saying you don't need to know the details. Leave that up to us. I understand that when hospital staff are burnt out and debriefing is not as compulsory as was in this instance for the hospital staff, because very often they do not have the energy to attend, it is impossible to engage and implement creative solutions that will benefit all the patients in the ward. For example, one could have had a rotation system where families can visit their loved ones at the window, each given a time during various days, so that there at least was not a complete absence of contact with the family. There's a lack of trust, if we can go to the next slide, that develops when things are completely contradictory, when information that is shared with the family between different service providers doesn't make sense, and when levels of healthcare staff do not understand the family and the personal motivation that arises. As you can see there, when my father came home, those stairs on the top right, we had to try and do something to ensure that he would approach them in a very meaningful way, because those are the stairs that my brother-in-law had hung himself on, and my father did not want to use those stairs as a result of that. Next picture. And you can see that even though the family is trying to cope, sometimes, as you can see there with my sister, they just don't. Next slide, please. Next slide, please. In South Africa, there has been an app that has been developed to try and improve care coordination. However, its uptake is slow and it does not include the family. If we can prevent falls, prevent cognitive regression, prevent long-term effects of trauma, there's a much more effective healthcare system than only allocating resources once these situations have actually occurred. That with compassion and care and incorporating the biopsychosocial and spiritual approach, the family's well-being can holistically be improved. That sometimes it's the small changes, like nurses plugging in the patient's cell phones at the beginning of the day if they cannot do this themselves because they cannot move, and as a result of dementia, they don't know where their phone is, and because of their poor hand coordination, they cannot plug the cell phones in. That might make it easier because the family won't keep calling the nurse's station and disrupt their duties throughout the day to try and speak to the family member. That the family member can provide intervention even if they are not there. They can assist with the lung exercises, their functioning will improve, which might be much more than the physio only offering the lung exercises twice a day. And that fairness and equity across all patients can be possible, but it does require a creative system change. Next slide, please. As we did in South Africa, really develop the slogan, we are stronger together. I want to end with that it is like that in our healthcare teams, but our healthcare teams consists of everyone, including the family, the household, and the community. And that through all of this, we really will be able to make a meaningful change. Thank you.
Well, Helga, that's absolutely wonderful and brilliant. And on behalf of all of us, I want to say thank you very much for sharing those personal experiences. What a way to illustrate the topic of complexity and inequalities and inequity in primary healthcare. Thank you very much for doing that. And your ending too, stronger together, and the emphasis on everyone who is involved in PHC, from policymakers right down to the providers of care, to understand the importance of bringing everybody together, not just the health workers, but also the families and the patients and the community where we live and work. So thank you for that. Now, I hope we've been writing down questions because we're coming.
We'll have to see how we can manage the time. I think you've got an opportunity, Joseph, for questions. Perhaps, I see there's only one. I'm not sure that it's one that any of the panelists could answer. We've only got one question, it seems, so far. What we can do is then just look at at opening the panel or the panel to questions and maybe comments, and I can just go through the ways in which people can provide feedback. I'm not sure that there's enough time to break up into groups at 3 o'clock. So do you think that we can break up into groups? I think rather let's just have a discussion.
Open discussion.
With a smaller group, it's about 36 people. I'm sure that we can get people to pick up their hands and give some feedback as well.
Yeah,
have a discussion in the group itself.
Yeah.
Okay.
So
the first question is, I think on a scale of 1 to 5, it's on the screen now. I hope you can see it. I don't know if anybody would like to respond to that, any of the panelists. And if you have any questions, feel free to add it. If you're on Menti, you can just click on it. You can, on any page, just click on the question at the corner and you'll be able to ask a question.
Well, if I may,
yes, go ahead.
comment on the question. The point is that the problems of primary healthcare are not problems of technology. They're problems of mindset. We have a healthcare system. I made a comment on the chat. We call it a health system, but if you look what we are doing, it's exactly what the greater thinkers have pointed out. You cannot understand the problem if you decontextualize it. We have a disease management system, and most of the healthcare providers, I point out my own profession as a doctor, doctors are ever more looking at focusing on one bit only. And if that becomes predominant, we lose all of what Helga, from her experience, has alluded to. Seeing it in context and providing adaptive responses to the constantly changing needs, whether there are biological, whether they're social, whether they're emotional, or whether they're cognitive, spiritual, doesn't really matter. Healthcare requires a constant awareness of the dimensions of health, as I pointed out, the four domains as I see it, and the adaptation and the pulling in, pulling out of providers that are needed or not needed any longer at a particular point in time. So it's not more, we don't need more information. We really need more thoughtful and compassionate approaches to thinking about what are the needs of the patient or the person we are caring for. If the patient is not the center of our endeavor, we will not get either a primary healthcare system or a health system that uses the wonderful things that technology can offer under certain circumstances for the exceptional patient. We waste our time, we waste our resources. And just to stay with how people are healthy and how people are ill, it follows a Pareto distribution or an 80-20 split. And that has been repeated all around the world since Kerr White published it first in the early 60s. 80% of the community are healthy enough not to require any health professional input. Leaves you with 20% of the community. 80% of those, or 16% of the total community, requires a primary care professional. That doesn't have to be a doctor. It can be a nurse, it can be a midwife, it can be a social worker, an occupational therapist, which then leaves you with another 20% or 4% of the total. They require specific interventions. They may need a gastroscopy or they need a knee replacement or whatever. Only 0.8% of the community requires a tertiary hospital. Think about it. Where do we teach? That comes back to what Joseph said earlier. We are teaching, or we take people out of their context and teach them in environments that have nothing to do anymore with the context they're coming from. And then when they come back, they're completely lost. It requires a mind shift, a different frame of thinking about who we are, where we are, what we need to do. And with that goes that we need to embrace what has become very clear from all of the presentations, a way of looking for the interconnections and the interdependencies, and looking for the dynamics, how they change, what are the feedbacks that make it better, what are the feedback loops in the system that make it worse.
So, and I think it's, if I may, so go ahead, Camille. Camille, go ahead.
Oh, yes. Sorry, I'd just like to comment. I'd like to, agree and also disagree. I think that having worked in primary healthcare transition funds and primary healthcare from a macro, micro, meso level as an evaluation, I think actually data is important. And I think good data is important, because if you're going to, and I think performance indicators are important. They're not the be all and end all, but I think they're important because they're markers. And I think we've got much better technology now to actually get better data and use the data in a more sophisticated way. So on the ground and on the care and on the, at the delivery and connections, yes, we need more people. We need more people skills. We need to get outside of these narrow frameworks. On the other hand, I think we also need good data and we need a good evaluation. And I think we have responsibilities at different levels to meet requirements of performance. So I think we've, and Akiko's presentation about, sentiment analysis. I mean, I think there's a lot of opportunity to enhance, but it shouldn't be the driver. It should be secondary to the core of care delivery.
Yeah, well, that's brilliant.
Just add.
Yeah, go ahead. Good. Just before you go, Akiko, I just want to encourage people. I think we're going to try and have some discussion up to 3:30, just to manage time. And we're going to include a few minutes where you give us feedback. So you can either add questions, by lifting your hand. You can also use the Q&A in the Menti. You can also add your questions into chat. We'll try and pick it up on that. If you have any comments, feel free to add them in the chat as well. If you'd like to raise your hand and contribute to the discussion or orally ask the question, just raise your hand, look at the reactions, and you can pick it up. So we're trying to give you as much of an opportunity to engage in this discussion. Feel free. So Akiko, go ahead. Sorry, Joseph, over to you.
Yes, I just wanted to build on Carmel's point about the importance of data. And I think we have to acknowledge that with the advent of technology and big data, for the first time, we really have tools that give us low-cost access to how we as human beings behave This sentiment analysis, I agree, it's not the be all and end all, but for the first time we have availability, how we behave as a group and how that affects how the healthcare system needs to respond. The fact that there is such an outbreak, almost like an inflammation of lack of trust that is happening around the globe. You know, the sentiment analysis using large data and just-in-time data gives you a sense of how much this information and sentiment is spreading around the world. In the infodemic, the misinformation related to COVID, we can capture that and to try to find an intervention to that, what messages. This is something that a lot of healthcare professionals are not trained to do. And I'm seeing this from a public health perspective, not a medical perspective. This is population health. And primary healthcare, how much is that connected to public health? Often it isn't. So this is where we need to close the gap. And I think technology allows us to get access to this kind of information in a timely manner that we could never see. So I agree, we need to have much better training on emotional intelligence, but at the micro level, at the patient-doctor level, you may miss out the whole pattern of what's going on, like the drug compliance being terrible because of an outbreak of doctors who do not speak in a way that is conducive to trusting behavior. I mean, that is a pattern that has to then be dealt with in long-term education and so forth. But anyway, just wanted to point out that I think technology is making a big impact and giving us a new perspective on how we're behaving, and that's important. Thanks.
Thank you. Innocent, I see your hand was up.
Yeah, thank you very much. And I would like to really thank all our panelists and presenters today. And I really can't agree with them more. It is true that in primary health care, we deal with the complexities, and I think that is where our problems have actually taken the niche. Looking at really using data, there is normally no way how we can avoid use of data, but I think the challenge is particularly in the low and middle income countries, where we really don't have well-developed health information and management systems. In many countries, particularly in Africa, where we are, like in Uganda, where I am, people still carry small notebooks, and that is where the clinicians jot down the notes. So you find that it becomes very difficult to actually generate data from PHC systems that will be easily interpreted for proper decision making. That is not to say that we don't have to find out how to do it. I think we should find, or we should try by all means to find ways on how to generate data to convince the policymakers and other stakeholders, because that is the only way. And I liked Joachim's statement that all we need is the mindset. And I think the fundamental question is, how do we start changing the mindset? Because it's not an easy way. Probably we need to find some models which have worked elsewhere on how to change the mindset, but it's quite difficult. However, I think we have no way around it. We have to start small, but continue, particularly to the policymakers and the politicians. I think it is Camille who talked about political will. But I think when you look at most of the PHC documents, and not even necessarily PHC, but all documents talking about health, people will always say PHC is the way to go. So on the face of it, the political will appears to be there, but what is actually lacking is the political commitment and the political action, that they can actually stop singing about the political will, but get committed to it and actually act on it to make sure that PHC is well established and is performing well to improve the health of the populations. Thank you very much. Really, these presentations are quite insightful. And I think once we start having similar voices talking about the same things, that is a good beginning. Probably once we keep our vision clear, we shall reach there. Thank you very much.
Thanks.
Thank you.
Joseph, can I just respond quickly, if you don't mind?
Yes.
I think there are also some questions popping up. Vivian and Pratyosa, I'm sure will give you a chance just now.
Yes.
I just want to raise the fact that in response to what Innocence just said, I think in some ways the ideas that have been put out about trying to be an influencer is an important one, that we have to get a very clear purpose that we see as AfroPHC, that we think, that we need to impart. And I think that these messages are emerging in a way that Joseph has presented as some core messages that ring home true. And we need to now package it in a way to policyholders, policymakers, and these workshops are in themselves, before we even get to the policymakers, the collective around the AfroPHC itself needs to get clearer with the ideas, clearer with the focus, clearer with the purpose and values as well, and then be able to find ways in which we can amplify the influence as we're going along. A lot of the the thoughts so far have been around the complexity at a provider-patient interaction level, and that context is in fact the core of it. And we tend to sometimes not realize the complexity of that engagement. And I think as we talk to more biopsychosocial approaches, it will become clearer that we need to include that. One of my challenges, and I'm pitching it to the panel, is that many of our policymakers have a very reductionist approach to policymaking in primary care in Africa, where there's a strong emphasis on verticalized programs. A key challenge is, yes, we can talk generically to teamwork and being able to deliver to care to a defined population. Do you think that there were any other key messages that we would be able to include in them to make policymakers or to pitch the way in which we think things should be going using the complexity theory? If you were to just look at saying, what would you think important to a policymaker to convince them of listening to AfroPHC in Africa? I don't know if there are any thoughts, and then we'll go to some questions. I think Pratyosa's got a hand up, and Vivian has got a question in the group, in the chat. Any thoughts? And this is more at organizational level, primary health care. A lot of the functioning of primary care is large centers that are like district hospitals, or very small, poorly sort of resourced small clinics scattered around, often depending on community health workers. Go ahead, Jochen.
Well, I think that's why I choose Alice's work and presented it here. It needs to come from the bottom up, and policymakers, one of the problems with them is they think they have to be in control. They have to dictate how it goes. They don't understand that policy making is about providing constraints. And part of the constraints is how much money you give to the system, but you also have to clearly identify what is it we want to achieve, and then let the people do what they need to do. If you recall the iceberg image I showed, the ones on the ground know everything. The ones at the top know very little, but think they have all the wisdom to tell everyone what to do. That is what I'm alluding to in terms of mind shift, creating different frameworks. The politicians, I think it's a worldwide phenomenon, are always interested only in how much does it cost, how much money do they spend. I'm not an accountant and I'm very bad at managing my own finances, but I know that a ledger has two sides. What you spend on one side is an income on the other side of the ledger. So use that metaphor. If they see putting money into healthcare as an investment, then it becomes a matter of what do I get back from that investment? And one thing you get back from your investment is good health of the people, who then can continue doing the things that have an economic benefit and help develop the community and the country, and that feeds back. So they don't understand feedback. I think that's one of the first things to contemplate as a means of getting to politicians. That they need to get away from that one-sided thing. Government is always only asked for spending money. They need to see what they get back for their see their spending as an investment, not as you and I would do when we decide to go to the baker or to the hardware store. It's not that one.
Thank you very much for that point. Helga, we'll soon come to you, but I think Pretiosia had a hand up. Can we hear from Pretiosia?
Go ahead.
Most of the things that I wanted to say, the previous prof has already alluded to it, because I just wanted to say these policymakers, the problem is that most of the problems which are encroaching, like he has rightly said, that the ones who are at the grassroots level are the ones who usually know exactly what needs to be changed and what needs to be done to improve the situation on the ground. Like the other professor has rightly said that you find that there is need for emotional intelligence. And the other person said also, how do we change the mindset of the policymakers and other people, as well as the priority providers, because you were talking about provider-patient interaction level, if I understood very well. But it all cascades from bottom to top. If these policymakers lack foresight and they do not see the need, because I've seen most of the politicians in Africa, they feel like health care services, they don't give them profits. There's no profit out of it. They have no vision, like what the prophet said, that they don't see that when we have got a healthy nation, even the country's wealth and everything improves, even our workers, and the country also develops. But to them, it seems like this is now a neglected area, the healthcare delivery system. And all those issues that we have been said, that you find doctors, the healthcare workers, at the end of the day, they don't even know how to interact well with their patients, and they don't even give feedback. It's because of burnout. And they have got one, financial constraints, burnout, and the policymakers are not even listening to the problems, shortage of resources, everything, staff, brain drain, attrition, you name it, as you have said. So the only way maybe for us to have policymakers who would listen to us, maybe if among healthcare workers, we diverge, instead of us only becoming doctors and nurses, maybe we end up trying by all means to reach to the level of policy making. And we go to that level. We have doctors and nurses who are also representatives in policy making. Probably they can change things up there, because the politicians themselves, I don't see any change coming in Africa.
Well, thank you very much, Pretiosia. Helga, please.
Thank you. It links to that, but more to what Joachim was saying in terms of the economic benefits and policymakers seeing the investment. An acute example is in this COSA program, the Community-Oriented Substance Use Program, which is funded in part by the city of Tshwane, who are constantly looking for measurable outcomes to prove that the investment that they make is delivering financial benefits. For example, the people who are then in the program being able to get employment. But you cannot look at those kinds of outcome measures in a country which has a high unemployment rate such as ours does, and also where the chances of them being able to enter formal sphere of employment are so low, considering the history which often involves incarceration amongst others. Therefore, what we are proposing or trying to bring across is that one has to look at the household improvement of what happens when someone is in the program. So, for example, with Maria, if she now has 3 children who are attending the COSA program, but none of the 3 children are still stealing from her, she is the one who can go and get the job. She is the one who can bring income to the household, and thus the entire household has a better well-being. But that's not on our outcome measures, and that's why people aren't seeing the benefits of the investments.
Thank you very much. To Camille Martin.
Yes, sorry, I just wanted to say that, and picking up from what Helga said, I think this is where you really need to get very good evaluation, and it doesn't have to be highly sophisticated. It has to be extremely well thought through, and it doesn't necessarily have to be super expensive, but it requires a lot of thinking. And I think this is where complexity science or complexity will have an impact, as Helga was saying. The sort of measures that come from the top, because I actually worked in that sort of level at one stage, they have to demonstrate to someone the accountability for the spending of money. So from the bottom, one of the things we can do is actually make better information for them. So I would say this type of thinking, complexity thinking, and analysis of what the real issues are, and the development of some metrics, I think is important to convince policymakers. So I suppose I'm an evaluator for some of my life, and I think that evaluation is very important as a feedback.
Sure. Yeah, Robert Oyedikwe.
Yes, good afternoon, everybody. Thank you so much to all the presenters.
Thank you.
I just want to add quickly that the presentations are typically what we've known, those of us who have been in primary healthcare for more than 40 years. Everything they've said is spot on. But I want to add that the root cause of this is that what we have in South Africa, I'll just give you an example, is the integrated development plan, which is usually run by the municipalities. And if you look at the way they run it, on paper, it's so good, but practically it's not implemented. So you get a lot of politicians come in and do what is called incremental budgeting. So there is no voter-centered planning. Once you don't have a centered planning, the result is you will always neglect the health system. And for the last 10 years worldwide, we saw gradual decrease, and in some countries, expensive decrease in the budget of health. And that is what is causing this problem. We need to go back to planning, like everyone has said, and use the information we gathered today and give it back to the framework planners, policy makers, politicians, and even ourselves in the health sector. That's my contribution. Thank you so much.
Oh, very kind. Thank you very much, Robert. And I was just going to say a number of things. One, the complexities we are talking about, and I referred to, I think it was Camille who said, no country yet has met the differences, fulfilled the expectations of primary health care. Yes, that is very true. But there are countries that have gone much further than the others. I make a reference to the UK National Health Service, for instance. The beauty of being a general practitioner in the NHS is this complexity issue. The fact that as a general practitioner, you get to your office any day and you're not quite sure, you don't know what's coming through the door. Unlike if you are in the hospital and you're a consultant, say a consultant urologist, you always know that a patient that passes through your door is going to have a urology problem. Why? Because there is somebody who is a gatekeeper, who is the generalist, who is the general practitioner, who is the family physician, who has done the sorting out. And in doing that sorting out, would have looked at both the biomedical aspects of the patient and the social determinant aspects of the patient as well. So it's a good thing to highlight the complexities, especially for those coming into the field at the moment in this world that has changed so much. And the challenge is that even in the UK itself, that beauty of primary health care is a complex system. Primary health care sees the patient not as headache or hypertension or abdominal pain, but sees the patient as a human being who has a medical problem, but also has social, economic, psychological, and other, interactive challenges. So I think the beauty of this discussion we're having is bringing up the fact that PHC is a good platform for really beginning to address it and understand it. And we should be sharing these messages with our colleagues in the specialty, in the hospital sector, so they can complement our efforts in the primary health care by seeing patients holistically rather than in the silos of disease. And on the issue of information, yes, I agree. We need information, but the emphasis needs to shift to more accurate information. It's absolutely crucial that we have that. We can't really do our work effectively without information, without data. And to move it further, data is important. If we're going to bring the politicians on board, then we need data we need to first try and educate them to understand what evidence-informed policymaking means, because most of them don't understand it. We in the professions of health and public health, and understand what information-driven decision means. I'm telling you, most of the politicians, at least where I am located in Nigeria, don't understand that. So we need to begin to educate them about the value of using accurate information to drive policy. And there was a comment made about making the politicians and the policymakers understand that health is an investment. Every politician I've met will always say that health is wealth. That's the mantra. But when it actually comes to practice, it's not, that's not what they do. They would always prefer a big hospital building or a big project that as people are passing by, they can point at it and say, yes, so-and-so politician was responsible for that. So what we need to do is to use, I give an example. What we did when we were introducing the clinical governance in Nigeria was to emphasize patient-centered care in all its ramifications, both biomedical and the social determinants of it. And once the patients started to feel that the health system in the state where we piloted it was responding, it was actually the patients themselves who started pushing on the politicians to invest more in the healthcare. We have an example of the Africa Abuja Declaration of 2001. Why is it that only one country out of 54 in 2021? I looked in the literature, and there's just one country, Rwanda, is the only country that actually has met that mandate since how many years ago? 20 years ago. So we need to begin to work to educate the politicians and policymakers, and we need to embed patient-centered care in our practices. The patients themselves become the agents of change. They become the ones who are going to be talking to, after all, the constituents of these politicians and these policymakers. And if they have a good experience when they pass through the health system, it begins to impact on the politicians. That's our experience. And I want to leave it at that at the moment. Okay.
I think, thank you. I don't know if there are any other questions or any other burning remarks, perhaps some closing remarks from the panelists, and then we can close. Joseph, do you think we can do that?
Okay. In the absence of any other questions, I want to thank those who were able to join us today. We don't take your time for granted. We thank you very much for being able to join this AfroPHC workshop session. And we hope that you found it useful and informative. And for the panelists, well, I can't thank you enough. from Dr. Joachim Stoneberg to Dr. Akiko Mida and Dr. Camille Martin and Helga Liszt. Thank you very much for the time and effort you've put to assemble your presentation. And I'll tell you, most of us, I can see the comments that most of the participants were on the chat list. They found it very useful and think you were right on spot. You'd hit the nail on the head. So thank you very much for being in the panel. And I'm sure that AfroPHC is very glad for that. And Professor Shelby Musa, as usual, for coordinating this and making the whole event flow very smoothly. Thank you from AfroPHC.
No, thank you, Joseph, Professor Anna, for coordinating the panel and moderating the panel. Really appreciate that. I think it makes my life so much easier. Just some closing remarks. Once again, thank you to all the panelists and to all of you for joining us. We are going to make the presentations available. The recording will also be available in a few days on the webpage for which you registered. Just don't forget to join AfroPHC and follow us on social media. And remember that we've got a whole bundle of other things happening. So go on the website, have a look at more. From AfroPHC and the panel, thank you very much for joining us. I think there's some wonderful remarks. We'll keep all of that, and we will certainly be including the discussions today into a document that we're trying to prepare for building the PHC team in Africa. So thank you. It's going to feature as a key element of that document. And so all the discussions will be very, very valuable. Thank you very much. Take care and be well. Bye-bye, everyone.
Yeah. Thanks, everyone.
It was a pleasure to take part.
You're
Thanks
welcome.
Thank you for
Have a good
inviting
day,
us.
everyone. Thank you, everyone. Thank you.
Bye.
Thank you. Bye.
Bye.